This talk is on primary open-angle glaucoma and juvenile open-angle glaucoma. Picture of a drain here, we'll get to that. Sometimes called chronic open-angle glaucoma, but I think primary is probably a better word, and certainly the word one will see most times in literature. Primary open-angle glaucoma is the most common form of glaucoma in the United States and most Western countries, in differentiation from Asia, where in many countries like China, angle closure glaucoma is more prevalent. It is a diagnosis of exclusion in that we try to find an underlying cause for the decreased aqueous outflow and increased intraocular pressure, things like exfoliation syndrome or pigmentary or steroids. So it's what's left over after everything else is ruled out, and it's sort of funny that the leftover is the most prevalent form of glaucoma. What we see is optic nerve head damage and visual field loss. That means that the patient has glaucoma, and that's unifying through all forms of glaucoma. Primary open-angle glaucoma has elevated intraocular pressure. That's by definition. So if they had cupping and field loss without elevated intraocular pressure, we would consider that normal tension glaucoma, although that differentiation is pretty arbitrary. There's no identifiable etiology for the increased intraocular pressure. So this is a drain, and the analogy that I use for my patients is that it's sort of like one sink. The sink might be overflowing, and you look at the drain, and the drain looks completely normal. And it's exactly the same in primary open-angle glaucoma. The intraocular pressure is elevated. We look at the trabecular meshwork, and it looks fine. We don't see anything in it. We don't see iris covering it or exfoliation syndrome or lots of pigmentation to indicate pigmentary glaucoma. It just looks normal. So there's an increased resistance to aqueous outflow through the trabecular meshwork. This is perhaps due to an increase in glycosaminoglycans in the meshwork. It is, as I said earlier, the most prevalent form of glaucoma in Western countries, in Europe, in the United States, in Canada, Australia. It has many risk factors. Age. So individuals in their 80s are at tenfold risk of developing glaucoma compared to people in their 40s. Race is a risk factor. In the United States, it's much more prevalent in those with African heritage, up to 16-fold times as prevalent. The African American individuals have a higher risk of blindness, up to 8-fold higher. Earlier onset glaucoma. But interestingly, in OATS, the racial risk factor was accounted for by the fact that people of African heritage have typically thinner corneas and larger cups. Family history is important. People who have a family history are at increased risk, up to 8 times higher than the general population, but certainly nothing like 50-50 risk. Substantially higher, but not high. Mycelium mutations are found in up to 5% of primary open-angle glaucoma patients. And in some of the books, there's confusion about the terminology. Mycelium and tiger are the same thing. Tiger is an older name for the same gene. GLC1A is simply the linkage site, so it's linked to chromosome 1Q. That was called GLCA until the gene was found, and now the gene is known to be mycelium, formerly known as tiger, but they are the same thing. Central corneal thickness, we know, is a risk factor for developing glaucoma. People who have thinner corneas are at a substantially higher risk of developing glaucoma. And obviously intraocular pressure is a risk factor for developing glaucoma. And it's something we spend a lot of time thinking about because on this list, it's the only thing that we can adjust. So even at relatively normal pressures, the risk for someone whose pressure is over 21 millimeters of mercury is 16-fold higher than a patient whose pressure is less than 16. So intraocular pressure has a huge impact on developing glaucoma, but it's not part of the definition of glaucoma. It is part of the definition of primary open-angle glaucoma because, by definition, people with primary open-angle glaucoma have an elevated intraocular pressure. There are other risk factors that are kind of variable, and I personally don't think of them clinically when I'm taking care of patients. Myopia is a minor risk factor in many but not all studies. Diabetes mellitus in some studies, but actually in oats, diabetes mellitus was protective, so that's not really an interesting risk factor for developing glaucoma. Elevated blood pressure, also not consistent. We do know that people who have established glaucoma, having low nocturnal blood pressure is a risk factor for progression of people who have established glaucoma. People with glaucoma are generally asymptomatic until late in the course of the disease, which of course is why there's so many undiagnosed cases running around. Late in the disease, they might have poor peripheral vision. They might notice that they're running into things. They almost all have poor vision in the dark. When you lose your peripheral visual field, you're also losing a lot of your night vision. It's usually bilateral. I've seen a few unilateral cases. It can be asymmetric, but it's almost always bilateral. The angles are open, hence the name, primary open-angle glaucoma. Elevated intraocular pressures. However, up to half of people who ultimately are found to have high-pressure glaucoma, or primary open-angle glaucoma, had normal pressures on presentation. They have optic nerve head cupping, like everybody who has glaucoma, and visual field loss. Typically treated with drops, and there's a whole section on drops and medical management, followed by trabeculoplasty, followed by incisional surgery. There are a lot of randomized clinical trials in glaucoma, and rather than clumping them all together, I thought I would talk about one here, and that's an early manifest glaucoma trial, the EMGT, which asks the question, does lowering intraocular pressure slow the progression of newly diagnosed open-angle glaucoma? It's a really beautifully designed study in that they didn't take glaucoma patients from clinics. They screened 2 Swedish cities and found new cases of glaucoma. So they screened individuals between 50 and 80 years of age. And these individuals who were newly diagnosed were randomly assigned to either no treatment versus a prescribed treatment regimen of Pataxolol plus argon laser trabeculoplasty. The endpoint was glaucoma defined as progression on visual field or optic nerve head photographs. So the main result was that in this study, those 2 treatments, Pataxolol plus trabeculoplasty, lowered pressure on average by 25%. And in multivariate analysis of the data, the progression of glaucoma was cut in half, cut by 50% in those who were treated. The risk factors for progression included exfoliation syndrome, kind of regardless of the pressure, even at low pressures, exfoliation syndrome patients are more likely to progress. Not surprisingly, people had more severe field loss at entry, lower perfusion pressure, in other words, low blood pressure compared to the intraocular pressure, and people who had disc hemorrhages are more likely to progress. And interestingly, in this study, not only were hemorrhages more common in eyes with lower pressure, we know that in, quote, normal tension, end quote, glaucoma, hemorrhages are more common, but the frequency of hemorrhages was not affected by lowering the intraocular pressure. Most people with primary open-angle glaucoma do well and maintain functional vision throughout their life, and those who do go on to blindness are often those who presented late with advanced damage. A special case is juvenile open-angle glaucoma. Those are individuals who develop glaucoma between the age of 3, which is the endpoint for primary congenital glaucoma because the eye stops growing in response to pressure at around age 3, and up to age 40. They have normal angle anatomy and often a very strong family history of glaucoma. If we see an individual has strongly dominant glaucoma, very high intraocular pressures at a very young age, there's a high likelihood that the patient has a mycelium mutation. So an individual who is 19 years old with pressures of 45 millimeters of mercury, whose mom and uncle have had glaucoma surgery, that sounds like mycelium to me. So the key points about primary open-angle glaucoma: it's the most common form of glaucoma in the U.S. and most Western countries. There's no identifiable etiology. Prevalence increases with advancing age. Individuals of African heritage within the United States are at a greater risk for developing glaucoma, and it's treated by lowering the intraocular pressure. Although that's only one of many risk factors, it's the only adjustable risk factor. It's interesting that primary open-angle glaucoma is the most prevalent glaucoma, certainly that I see in my clinic, but there's really not that much to say about it because all of the other talks in general, when we talk about appearance of the optic nerve and the visual field and therapeutic regimens, really in many ways are dealing with primary open-angle glaucoma.